This is lecture number 2 of the urinary system, chapter 15 of Hagen Ansert, and it's on renal variants and pathology. The renal variants we're going to cover today include prominent columns of Burton, dromedary hump, junctional parenchymal defect, lobar dysmorphism, fetal lobulation, sinus lipomatosis, and extrarenal pelvis. We're going to start with prominent columns of Burton. And the columns of Burton are a normal part of the kidney. They contain the renal pyramids, and they sit in between the sections of the renal medullary substance. So if you have a prominent column of Burton, it just tends to be a hypertrophied one with a large invagination into the medullary substance. It can, however, look like an avascular neoplasm, and we're going to see it most commonly in patients who have duplication of the collecting system, whether it's partial or complete. And I'm going to point this out to you. Here we go. So here where these arrows are, this is the prominent column of Burton right here. Next up on the list was dromedary hump, and it's called this because it resembles the hump of a camel. We see it more often on the left kidney than on the right kidney, and it's a bulge of cortical tissue on the lateral surface of the kidney. Again, the differential is going to be a renal neoplasm, so you just want to be real careful that you don't mistake it for that. And in this case, what we usually have is a nice smooth curve of the kidney here on the outline, but you can see here we've got this sort of bump in the kidney. It goes up and then comes back down, like the hump on a camel. Junctional parenchymal defects, I like to think of these as the chocolate chip cookie that's missing a chip. It's like somebody either took a little bite out of the cookie or popped off one of the chocolate chips that sit on the edge. What you get is a little triangular sort of like indentation into the cortex of the kidney. We can see it there where the arrows are and where I'm pointing out the little V. It's triangular, it's usually echogenic, typically located in the superior and anterior part of the kidney, and it's the result of a partial fusion of two embryonic parenchymal masses called ranunculi. They're a part of normal fetal development, but what happens is they don't quite fuse correctly, so you get this little parenchymal defect. Lobar dysmorphism, this is one that may trip you up if you see it because it does resemble a mass or a prominent column of Burton, and you're not entirely sure sometimes what you're looking at. It happens because there's a variant in the fusion of the embryologic development, so the renal lobes, as they come together, it'll malrotate, and where it malrotates, the calyces on either side of it can be splayed and displaced, and the lower calyx becomes displaced sort of posterior. Fetal lobulation is also a developmental variation. Usually we see it in children up to age 5 years of age, and it can be seen in about half of adults as well. The surface of the kidneys are indented between the calyces so that it gets more of a head of broccoli appearance than that smooth kidney bean appearance that we're used to. So you can see here, right, we got a nice smooth posterior border, but then as we come up, we get these little indentations that make the renal lobes sort of stick out. Then there's sinus lipomatosis. This is a condition in which a moderate amount of fat becomes deposited in the renal sinus. And what we see is an overdeveloped echogenic renal sinus and a thinner cortex than what we would expect. So we get atrophy of the parenchymal part of the kidney. You're going to see abundant fibrous tissue that can cause that thinning and that enlargement. And there is something known as lipomatosis circumscripta. I'm going to let you look that one up in your book. But what you're going to see is that sort of overgrown sinus like we have here, and then notice that the cortex, the hypoechoic part of the kidney, is thinner in this patient. All right, extrarenal pelvis. I call this the droopy drawer syndrome of the kidney. So the normal pelvis is sort of triangular, and the base of the triangle sits up in the kidney itself, and then the apex points inferior and medially. I'm going to show this to you on a picture in just a moment. With extrarenal pelvis, the pelvis is larger, it's got long major calyces, and the pelvis itself seems to sit outside the hilum of the kidney. The pelvis is going to look like a central cystic area, and it'll be beyond or partially beyond the confines of the bulk of the renal substance. And here you can see a normal kidney versus an extrarenal pelvis. So normal kidneys, most of that pelvis is sitting up here inside the hilum of the kidney, and you just have that little narrow part of the apex of the triangle that exits the hilum of the kidney and then forms the ureter. With extrarenal pelvis, that bulges out and drops down, sometimes partially outside of the hilum or sometimes completely outside of the hilum. And this is going to be filled with urine, and you're going to see it as a cystic structure on ultrasound. It will look something like this. So what you're looking at here, because this is not a great picture, you've got renal cortex here, renal sinus here. Renal cortex extends out of our picture and comes around this way as well. And then we have this cystic structure here. It can sometimes be hard to tell if you're looking at extrarenal pelvis or if you're looking at a cyst, but if you follow it down, you can probably see the extrarenal pelvis is going to communicate with the ureter. That covers renal variants. Let's go ahead and talk about renal anomalies. The anomalies that we're going to cover are pseudotumor, renal agenesis, renal hypoplasia, bifid renal pelvis, incomplete and complete duplication, renal ectopia, and horseshoe kidney. One of them that we're not going to talk about that you want to be aware of is also the cake kidney. We're going to cover a couple of these on each slide just to keep the number of slides down. So pseudotumor, what you want to know about this is that it's an overgrowth of cortical tissue that indents the echogenic renal sinus. So it can be mistaken for a renal tumor on sonography. Another differential for this is going to be prominent column of Burton. It's going to look very similar to that. Now, renal agenesis is absence of the kidney or failure to form during embryologic development. And if it's a unilateral renal agenesis, you're just going to have one kidney. It's usually going to be hypertrophic because it's doing the job of two kidneys. And it may even be more prone to hydronephrosis. If it's bilateral, this is incompatible with life. It's also called Potter syndrome, is one bilateral renal agenesis syndrome. And these babies typically, if they make it to birth, do not live very long. Bilateral renal agenesis is very rare, and it's typically, if you have differences in kidney development, you're also probably going to have congenital anomalies of the reproductive organs, because the kidneys and the reproductive organs are going to develop at the same time. So something that disrupts kidney development may also disrupt reproductive development. Renal hypoplasia is different than renal agenesis in that the kidney does form, but it's going to have incomplete development of the kidney. So typically we had those 8 to 12 calyces. With renal hypoplasia, you're looking at probably fewer than 5 calyces. Now, functionally and morphologically, the kidney is normal. It's just small. So it works. It looks normal. It's just smaller than you would typically expect it to be. So you want to make sure that it's not kidney atrophy, that it's not an atrophic kidney secondary to something like pyelonephritis or chronic kidney disease or renal artery stenosis. So what you want to do is check those things that would go along with those pathologies and make sure that they are absent. So with chronic kidney disease, as the kidney atrophies, it tends to get isoechoic to the surrounding tissues. It becomes very hard to see. If it's pyelonephritis, you're going to see some scarring, and you may actually even see the pyo in there. And then with renal artery stenosis, right, if that's the reason the kidney has become atrophic, you can Doppler the renal arteries and get a waveform and see if it looks normal or not. If the waveform is normal, there's no scarring, there's no pyo, it's probably renal hyperplasia. Now with bifid renal pelvis, this is a common renal anomaly where we have a duplication of the pelvis and one ureter. So it falls into two categories, either incomplete or partial duplication, or it can be a complete duplication all the way down to the bladder, and we're going to look at that on the next slide. Incomplete duplication is going to be your most frequent congenital anomaly seen in neonates, and what you have is two collecting systems, two ureters. At the level of the kidney, you're going to have two collecting systems and two ureters, but where they enter the bladder, there's only going to be a single ureter, because somewhere between the kidneys and the bladder, those two ureters are going to come together and fuse, and only a single ureter will enter the bladder. Now, you can usually see this sonographically, or the evidence of it sonographically, by looking for a cleft in the renal sinus. So when we look at the kidney, right, we've got that hypoechoic renal sinus, and then we've got that outer cortex that's sort of hypoechoic, mid-level echoes. With duplication, you will often see an interruption in the sinus where there will be what looks like cortex bifurcating the sinus. So that's one sonographic indicator of a possible bifid collecting system. Now, a complete duplication, this is more rare, and you get two ureters, two pelvises, and also the ureters are going to both enter the bladder separately. The risk for pre-vesicoureteral reflux is greater in these patients, so that means that the urine is able to back up into the ureter or into the kidney. And they're also going to be at a higher risk of obstruction or stricture, by stricture or by ureterocele, and this is because it's going to have an ectopic insertion into the bladder, meaning one of the ureters is not going to enter the bladder at the normal place because there's two entering the bladder. And sonographically, you can prove or demonstrate complete duplication by seeing two ureteral jets on one side of the bladder and a third ureteral jet on the other side of the bladder. Moving on to renal ectopia, this is going to describe a kidney that's not located where it should be, not in its typical or usual place. Now, the kidneys in fetal development, they start low in the pelvis and more medial, and as the baby develops, those kidneys are going to move more lateral, and they're going to ascend from the pelvis into the abdomen to their typical normal site where we would find them under the spleen and under the liver. If one of them fails to ascend from the pelvis, and it's usually one, your ectopic kidney is most often going to be found in the pelvis because of that. It just fails to ascend. Sometimes it's going to ascend too high and it's going to end up north of the diaphragm in the thorax. That's a problem too. Either way, the ectopic kidney is often malrotated, and it's going to be at a higher risk for reflux, infection, obstruction, and stone formation. It's very rare that this is bilateral. It's typically only one side or the other. And thoracic kidneys are even more rare than bilateral pelvic kidneys. The next one is called horseshoe kidney, and this is a fusion anomaly. So They start in the pelvis and they're more midline. So what happens is the lower poles of the two kidneys are going to fuse together in 96% of the cases. This is your most common fusion anomaly. Problems with it can be, again, that malrotation, because they can't move where they're supposed to go, so they end up malrotated. Urolithiasis, which is stones, right, in the kidney or in the ureter. Uretopelvic junction obstructions, and infection. When the ureters are short, if you get a bladder infection, you're more likely to get a kidney infection because the bacteria does not have to travel as far to get to the kidneys as it does if the kidneys are up where they're supposed to be. So you're more likely to get infection if you have horseshoe kidney. On ultrasound, there's different ways that this can look. It might simulate a solid pelvic mass because it's going to be located anterior to the spine, midline, typically right around where the aortic bifurcation is. Or it can look like enlarged lymph nodes. Sonographically, probably the most common finding is going to be that you cannot make out the lower pole. So you'll be trying to, you'll think it's hidden by bowel or something like that. You'll be trying to make out that lower pole, and you'll just try everything that you've been taught, all the tips and tricks that you know, and nothing will work to make out that lower pole and get it nice and clear so you can get a good measurement. So oftentimes horseshoe kidney is missed over and over again because it's assumed that the lower pole is obscured by bowel gas. So if you're having that problem, go to the other kidney, see if you can make out the lower pole on it. If you can't make out the lower pole on either of them, try a more medial window and a lower window than what you would normally look for the kidneys. So this is just illustrations demonstrating all of those things we just talked about, or a few of those things we just talked about. Here we've got that bifid renal pelvis with the duplicated collecting system. We can only see the proximal part of these ureters, so we don't know if they're going to fuse somewhere below, so we don't know if this is an incomplete or a complete duplication. Here we have an ectopic kidney. Let me put on my laser pointer. There we go. So bifid system here, ectopic kidney system here. You can see that kidney's low in the pelvis, and it's attached into the iliac vessels, not where it should be, up where the renal vessels would normally be. Okay, so keep that in mind. Notice that short ureter on this attaching it to the bladder. And here is our horseshoe-shaped kidney. Now, when this happens, those renal vessels tend to be lower than you would typically expect to find them, but not as low as you would see them with an ectopic. That's going to bring us into anomalies of the ureter, and most of these are going to be strictures, okay? So that's going to be a narrowing of the ureter, and it can happen for any number of reasons. Causes include fibrosis, inflammatory disease, tuberculosis can scar that ureter, periureteral fibrosis, impacted stones. Stones can get stuck in there and cause obstruction. Schistosomiasis, iatrogenic ureteral injury. Okay. Radiation therapy, amyloidosis, adjacent malignancies, metastases, retroperitoneal tumors, and enlarged lymph nodes. So it occurred to me after the end of that last slide that I should have described what iatrogenic means. So iatrogenic means that the cause is related to medical exam or treatment. So it's typically something that's happened because of a medical intervention. So that would be a cause of stricture too, so like post-surgical. Okay. Now, ureteroceles, these are cyst-like enlargements of the lower end of the ureter. These can be congenital or acquired. Usually they're small and they're asymptomatic. Patients don't have any problem with them, but they can cause obstruction, and they can cause, they're more prone to infection of the upper urinary system than someone who does not have one. We typically see them more often in adults, and what you want to look for is the cobra head appearance on sonography. So if we look at this image over here, we can see that what happens is that ureter gets dilated, almost aneurysmal or cyst-like on the end, and it protrudes into the bladder itself, where it enters the bladder. So then what you get is this sort of like balloon-like looking structure inside the bladder. Okay, that's what a ureterocele is going to look like. So ectopic ureteroceles are going to be ureteroceles that are associated with ectopic insertion. If you'll recall, we said those complete duplication of the ureter system causes an ectopic insertion into the bladder. So an ectopic ureterocele is going to be very rare, just like complete duplication is. It's going to be more commonly found in female children and young adults. And it's going to look very similar to regular ureteroceles, but you might see that it's in a different part of the bladder than you would expect. That brings us to the bladder. Now, ultrasound is not the modality of choice when we're looking for early neoplasms of the bladder. Cystoscopy is going to be more often used to examine the bladder because it can diagnose those early neoplasms, and that's the insertion of a camera up through the urethra and into the bladder. We can do transurethral or intraurethral, intravesical ultrasound now, so we are seeing more of that going on as well in addition to the cystoscopy. Transabdominal sonography is going to allow visualization of most lesions that have reached 5 millimeters in size or greater. What you should expect is that the bladder wall will be smooth and it should measure 3 to 6 millimeters. Most of your neoplasms are going to grow along the bladder wall, so you want to look for asymmetry. Does one side look thicker or more rough or bumpier than the other side? Look for any sort of like outpouchings or growths on the wall itself, and then evaluate the residual volume and look for ureteral jets. So here I just want you to pause and see if you can name 10 conditions that cause incomplete emptying of the bladder. How did you do? That concludes variants and anomalies. We're going to move right into pathologies. Renal masses are going to be categorized with sonography as either cystic, solid, or complex. Cystic masses are going to be smooth, thin, they're going to have a well-defined border, a round or oval shape. There will be a clear delineation between the cyst and the renal parenchyma, and it will be anechoic, so no internal echoes, with increased posterior acoustic enhancement, that brightness behind the cyst. Solid masses can have varying appearances. They can have irregular borders, poorly defined interfaces between the mass and the kidney, so they can be isoechoic to the surrounding tissue, low-level internal echoes. They may have weak posterior borders because of the attenuation of the mass, so the mass is going to weaken the sound beam more than the regular surrounding tissue, and you're going to end up seeing poor through transmission. Complex masses are any combination of the above. They're going to have areas of cystic appearance and areas of solid appearance, and they can have necrosis, hemorrhage, abscess, or that you may even see calcifications within the mass. Signs and symptoms of kidney disease. Flank pain is going to be one of the main ones if you have a kidney infection. Hematuria, proteinuria, fever, increased white cell count, elevated lab values, palpable masses, sometimes we can actually feel them, and vomiting. Because so many of these clinical symptoms that the patient reports to us are sort of non-specific for kidney disease in and of itself, fever, vomiting, pain, those sorts of things. We really rely on the lab values to determine that it's renal in origin, and also on the imaging. So we're going to start by looking at cystic disease. Simple renal cystic disease is going to encompass a wide range of disease processes, typical, complicated, or atypical. The most common is going to be your simple acquired renal cyst. Okay, they can be acquired or they can be inherited, and they can occur in the cortex, the medulla, or the renal sinus. Simple renal cysts are very common. They're typically an acquired lesion. We think they come from obstructed ducts or tubules, and the estimated incidence is that half the population over the age of 50 will have a simple renal cyst. They can come and go, so they may have a renal cyst and then it resolves. They typically are going to be asymptomatic, and they're an incidental finding done during other imaging. They can be solitary or multiple. They can involve one kidney or both kidneys, and they can get a little complicated. If the complications that arise from simple renal cysts are going to be bleeding into it, so hemorrhage, infection, they can become calcified or they can turn into a complex cyst. In the pediatric patient, we want to differentiate benign cysts, simple cysts, from a cystic form of nephroblastoma called Wilms tumor. Wilms tumor, there is one form of that is cystic in nature, and you definitely don't want to mistake that for a simple cyst. So here's what they're going to look like. Here we have the kidney. Now the cortex of this kidney looks a little dark because I think we've got a rib shadow here, and then we've also turned on the color Doppler, which tends to darken the grayscale a little bit. But if you look here in the box, you can see that there's normal renal cortex here, and we have this anechoic circular structure with posterior acoustic enhancement that is a cyst in the superior pole. Over here, we've got an older image. So the resolution's not quite as clear as it could be, but we've got our kidney right here. And here in the anterior lower pole, we have a rather large cyst. These internal echoes are most likely artifact. Typically, this looks like it's probably a simple cyst as well with posterior acoustic enhancement. Now, complex cysts are cysts that have internal echoes of some sort. These can be septations, internal debris. They might have thick walls. There could be calcifications, or you may see what we call mural nodularity, which is a sort of like solid component within the cyst. So if our cyst is round, and then we have this little solid component in there, that would be a mural nodularity. With complex cysts, we're going to consider them malignant until they're proven benign. Essentially, any mass in the kidney is cancer until proven otherwise, unless it's a simple cyst. Okay, and internal echoes are usually going to be the result of protein content, hemorrhage, or infection. If there's any irregularity at the base of the cyst, you should consider it a malignant growth. If the septations are thicker than 1 millimeter, or if they have vascularity when you put the color Doppler on them, then the lesion is presumed to be malignant. And here we just have a couple examples of complex cysts. So you can see the cystic structure right here. It's definitely not anechoic. We've got a septation in there. We got lots of internal debris. Don't know exactly what's going on with this one. Over here, same thing. We've got what appears to be mostly a cystic structure, but notice that the wall is not well defined, smooth, and thin, right? We get these sort of like indents and lobulations or irregularities to the shape of the cyst. And again, we got a lot of internal debris and echoes going on in there. Parapelvic cysts are going to have a similar appearance to simple cysts. They originate from the renal sinus, and they're most likely lymphatic in origin. So the fluid inside these cysts is typically lymph. They're not going to communicate with the collecting system. Largely, they're going to be asymptomatic, and it can be very difficult to tell if you're dealing with a parapelvic cyst or just a simple renal cyst. So the next three are going to be renal cysts that are associated with renal neoplasms. We're going to talk about von Hippel-Lindau, tuberous sclerosis, and acquired cystic kidney disease. Von Hippel-Lindau is an autosomal dominant disorder that's characterized by cysts and tumors in locations throughout the body. These include renal adenocarcinomas, which is the biggest problem when we're talking about the kidneys, and von Hippel-Lindau. And usually they're going to be bilateral and multifocal. Tuberous sclerosis is also autosomal dominant, and it's characterized by mental retardation and seizures, associated with an incidence of multiple renal cysts and angiomyolipomas. Now, you want to be careful with tuberous sclerosis. Definitely pay attention to the rest of your patient, because the differential diagnosis is going to be autosomal dominant polycystic kidney disease. But that one doesn't always come with mental retardation and seizures, so know your patient so that you know the difference. And acquired cystic kidney disease, this is most often seen in patients with chronic kidney disease that are undergoing dialysis. As the patients undergo dialysis, the longer they're on it, the higher the incidence of renal cysts, adenomas, and carcinomas than the general population. And if they're on dialysis for up to 5 years, at that 5th year mark, their risk is going to increase by about 90%. Oftentimes, these cysts can spontaneously bleed or hemorrhage. Polycystic kidney disease has been mentioned previously in a couple slides. There are two different kinds of this. The autosomal recessive polycystic kidney disease is rare and typically is associated with chromosome 6. We used to call this juvenile polycystic kidney disease because we see it more often in infants and children. And it has 4 different forms that are dependent upon when it presents itself. So there's like the perinatal, the infantile, and then there's 2 more, the last of which is juvenile. So if it's found perinatal, like pre-birth, it's typically going to be associated with fatal renal failure. The further along they are, then sometimes the prognosis is a little better, but that would be the recessive gene, and so both parents have to be carriers in order for the patient to have ARPKD. Autosomal dominant polycystic kidney disease used to be known as adult polycystic kidney disease. It is more common, and the severity is going to depend on the genotype. Type 1, which is the more common form, is more severe than type 2. In both cases, what you're going to see are multiple cysts. They're going to have a very similar appearance to them. Kidneys are going to be enlarged with multiple cysts. You may even see obliteration of the renal parenchyma. And here's just a few examples of what those polycystic kidney diseases are going to look like. I also want to mention that with the autosomal dominant, you may see that there are cysts in other organs as well, such as the liver or the pancreas. We've talked about ADPKD in conjunction with those chapters as well. So here's our kidney with a number of cysts in it. Here's yet another kidney. We can see a cyst here, a cyst here, cyst here, cyst here, cyst here. And then in this kidney, we almost can't make out any actual kidney parenchyma because of the number of cysts that are involved there, multiple tiny cysts in this case. So we have yet another kidney disease here. I call these the alphabet soups of kidney diseases because you've got your ARPKD, your ADPKD, and your MCDK as well, multicystic dysplastic kidney. This one's common, non-hereditary, and it's renal dysplasia. So this does not have a genetic component to it. It's the most common form of cystic disease you're going to see in neonates, and it's thought to be caused by early in utero urinary tract obstruction. So something happens that obstructs that urinary tract, and so that urine is going to back up and form a cystic disease in the kidney. Typically, it's going to be unilateral. The dysplastic change typically involves the entire kidney, and it's not common to see it in segmental or focal parts of the kidney. It typically is the whole thing. There's going to be poor function in that kidney. Dysplastic means that it's got dysplasia, which means that it didn't develop correctly. Something interfered with the development. It can be bilateral. That happens to be rare, but if it is bilateral, it's going to be incompatible with life, as we talked about before with bilateral renal agenesis. If these babies make it to birth, they don't live very long. Complications from MCDK can include hypertension, hematuria, infection, and flank pain. And there is a small increase in the risk of malignancy if the kidney is not removed. So a lot of them are going to have that kidney removed just to make sure that there's no concerns about malignancy, or to treat those complications. If they're having a hard time with complications that are interfering with quality of life, the kidney will be removed. And here you go, and a few more initials for you. MSK, medullary sponge kidney. This is medullary cystic disease. It's a developmental anomaly that occurs in the pyramids. So what you get is cystic or fusiform dilation of the distal collecting ducts, the ducts of Bellini, which is not a word we've seen before, but they're going to be those distal ducts, the very small ones that the little nephrons dump into. Dilation is going to cause stasis of the urine and stone formation. So MSK is an anatomic defect, and therefore it can be either unilateral or it can be segmental, meaning it only affects part of the kidney. Many of the patients are asymptomatic, but patients who have hematuria, infection, and renal stones should be evaluated for medullary sponge kidney. Medullary sponge kidney is going to be associated with a variety of other disorders. So things like Beckwith-Wiedemann syndrome, polycystic kidney disease, Caroli disease, which you'll recall was a disease of the biliary system, congenital hepatic fibrosis, and medullary cystic disease, nephronophthisis. Okay, what you're going to see is a kidney that looks sort of stony. Okay, so that what you get are these hyperechoic sections where the sinus appears to have taken over the entire kidney, and you get a very, very thin renal cortex with these sort of like invaginations of cortical tissue. Medullary cystic kidney disease and nephronophthisis. These are inherited disorders that lead to ESRD, and they share many features. They can cause cysts, tubular atrophy, interstitial fibrosis. Both of them lead to that scarring of the kidney that gives us that stony appearance that we looked at on the previous slide. What happens is the patients are not concentrating their urine enough, so this is going to lead to excessive urine production. We're going to see MCKD in older patients and NPH in younger children. They have many of the same features and they share many of the same symptoms. So before we talk about renal cell carcinoma, I'm going to back up to the last slide just briefly. I should have probably explained what ESRD is. ESRD stands for end-stage renal disease. So both of those previous conditions can lead to end-stage renal disease, which is when the kidneys completely cease functioning and the patient must go on dialysis to live. Now, renal cell carcinoma. This is also called hypernephroma or Grawitz tumor. Those are it's the most common of all of the renal neoplasms. Men are twice as likely to get it as women, and we see it most often in the 6th or 7th decade of life. The clinical presentation is nonspecific, so they may be asymptomatic in the early stages, And then they may start to report hematuria, some flank pain, or a palpable mass. And that's going to be what brings them in for imaging. So with renal cell carcinoma, the appearance is almost always going to be solid. It's going to appear bilaterally in a very small percentage of cases, 0.1 to 1.5%, but it is multifocal in about 13% of cases, meaning there's typically more than one lesion. And typically, as I said, solid. There's no predilection for either the right or left kidney or for its location in the organ itself. So it can happen in either kidney and it can happen anywhere in the kidney. Even though most of them are solid, occasionally we will see a predominantly cystic lesion, meaning that it'll have a complex cystic appearance to it. Very, very rarely is it entirely cystic. So this is why we say unless it's a simple cyst, the assumption is it's cancer until proven otherwise. Simple cysts are very, very rarely going to actually be renal cell carcinoma. Now in this slide, we have a kidney right here. It's a little hard to see. It's a transverse kidney. And we actually have two masses. We have a cyst up here with what could be internal debris, but I expect that this is probably because it's an older image and it's not the resolution's not great on it. But in addition to the simple cyst, over here we have a solid mass that is renal cell carcinoma. So one of the things that I like about this slide is it really teaches you not to get tunnel vision. Don't see the elephant in the room and miss the dark horse. Okay? Don't get so tunneled in on the benign lesion that you miss the malignant lesion. Another form of cancer that we will see in the kidneys is called transitional cell carcinoma. This can be a couple different kinds. It can be papillary or it can be flat. The papillary is more common. And the papillary is going to have a polypoid appearance attached to the mucosa. This is a low-grade malignancy, so it tends to have a more benign course. It doesn't grow as fast, and it tends to not invade other organs like the lymph nodes. The small transitional cell carcinomas, they're going to tend to be flat, and flat is a little bit more of a problem. The flat ones are going to be high-grade malignancy, meaning they're likely to invade other organs. They're likely to spread through the bloodstream or through the lymphatic system as well. You may see gross or microscopic hematuria and flank pain. And the differential diagnosis is going to be any other tumor of the renal pelvis. That could be squamous cell tumor, adenomas, blood clots even, or fungus balls. We won't know until it's biopsied. But as I said before, anything that's not a simple cyst, we're going to assume is cancer until proven otherwise. So the thing about transitional cell carcinoma is that it's not going to disrupt the renal contour the way some of the other cancers do. It tends to form an infiltrating mass that stays within the renal parenchyma, so that contour, that smooth border, is typically preserved. If it's going to spread, it tends to spread into the collecting system. It's going to have low vascularity on color Doppler, and calcifications are very rare. So here we're talking, right here is that transitional cell carcinoma. Squamous cell carcinoma is rare, but it is a very highly invasive tumor with a very poor prognosis. It tends to be aggressive. So clinical findings are going to be history of chronic irritation and gross hematuria as opposed to microscopic hematuria. They're going to have palpable kidneys secondary to severe hydronephrosis. The mass is typically large. You'll see it very evident in the renal pelvis. and you may see stones forming with this carcinoma, so you may see obstruction from kidney stones also present. So renal lymphoma comes in two forms, a primary form and a secondary form. The primary form is rare. The secondary form is going to be more common. And the secondary form occurs as a hematogenous spread or as a direct extension via the retroperitoneal lymphatic channels with contiguous spread from the retroperitoneum. So what that means is it invades the kidneys from the lymphatic system or through the blood vessels. Non-Hodgkin's lymphoma is more common than Hodgkin's, and lymphoma is more common as a bilateral invasion with multiple nodules. So if one kidney is involved, very likely the other kidney is going to be involved as well. Now, lymphoma is the one you have to watch out for because it can be mistaken for a simple renal cyst. Because it's going to mimic it occasionally. The kidneys are going to be enlarged. The lymphoma is typically hypoechoic relative to the renal parenchyma, so it can look like a renal cyst. Look for the acoustic enhancement. A simple renal cyst is going to have posterior acoustic enhancement. Lymphomas often will not have that enhancement. Sometimes it will have a halo of hypoechoic mass in the perinephric region, but that's very rare. And then again, you want to look to make sure that you've got margins and that you can look for that posterior acoustic enhancement so you don't mistake it for a renal cyst. In this case, our lymphoma is right here. It's isoechoic, slightly hypoechoic to the rest of the renal cortex. It does not look like a cyst in this case. And of course, as with every other organ, we have to talk about metastases. Renal involvement in other cancers is fairly common. The most likely places to see it are from lung, breast, or renal cell carcinoma of the contralateral kidney. So if your right kidney has renal cell carcinoma, your left kidney may get metastases. What you're going to look for, you're going to look for multiple poorly marginated hypoechoic masses. You may see renal enlargement without a discrete mass, so you may not be able to make out borders of a mass, but something may just not look right to you. And the tumor can spread beyond the renal capsule, meaning you get that misshapen or disruption of the capsule and invade the venous channel as well. So the tumor can extend through the renal vein and into the IVC, and then can grow from the IVC up into the right atrium of the heart, and eventually it will metastasize into the lungs as it hits that hematogenous channel and goes through the pulmonary arteries to the lungs. It can be multifocal, but that is uncommon. So you do want to know this about it, that the renal cell carcinoma is one that will grow through the renal veins and invade the IVC. That typically shows up on tests. We also have to talk about nephroblastomas. This is a pediatric malignancy, okay? It's the most common abdominal malignancy and the most common solid renal tumor in pediatric patients. You do want to know that. This one also shows up on tests. Peak incidence is going to be between 2.5 and 3 years of age, and nephroblastoma is 2 to 8 times more common in patients who have horseshoe kidneys. So horseshoe kidney is a risk factor for nephroblastoma. Clinical signs are going to include abdominal flank mass, hematuria, fever, and anorexia. Now remember, with these nephroblastomas, you have to be careful because they can be cystic in nature. So you want to determine whether the mass is cystic or solid and confirm that it is renal in origin, because there are other things in pediatric patients that it could be growing off of, like the adrenal gland or the liver. The mass is going to vary from hypoechoic to moderately echogenic, so it's going to have a variable appearance. Between 5 and 10% of cases are going to develop bilateral tumors. So careful evaluation of the kidneys, both kidneys, is crucial. The chances for survival is going to go up if it's only unilateral. So up to 40% of patients with Wilms tumors are going to have renal vein thrombosis, or they're going to have IVC or atrial thrombosis at the time of diagnosis. So these babies are sick. And the venous obstruction can result with findings, again, of leg edema, varicocele, or Budd-Chiari syndrome. You'll recall we talked about Budd-Chiari syndrome in the liver chapter. So these are just a couple ways that Wilms tumors can appear, but do not get hung up on these because the appearance can be variable. So in this first one, here's our pediatric kidney right here. And most of the kidney is taken up by this Wilms tumor right in the center. Now, likely out here, these are possibly medullary pyramids that have been pushed aside by the tumor. Over here, you can't even really make out any normal renal parenchyma. You just have this huge mass that looks both cystic and solid. Now, there are some benign renal tumors out there, but they're very rare, and as I said, all renal tumors are assumed to be malignant until proven otherwise. Typically with the benign ones, the patients are asymptomatic. However, if the tumor gets large enough, flank pain can present, and as can hemorrhaging from the mass. Adenomas and oncocytomas are going to be your two most common kinds of benign renal tumors, but be aware that adenomas and oncocytomas are very rare in kidneys. Your most common benign renal tumor is going to be an angiomyolipoma, and it's composed of fat, muscle, and blood vessels. It's going to be found in patients who have tuberous sclerosis. It goes along with tuberous sclerosis. We'll see it in about 80% of those patients. Size can be variable. Typically they're small, but they can get as big as 20 centimeters. And they may be multifocal, so there may be more than one. They're going to be very hyperechoic, and typically you're going to see them in the renal cortex. So when we look here, we can see the kidney here, and that angiomyolipoma shows up in the cortex as an echogenic focus. Same thing in transverse. Here's our kidney here, and in that cortex we have that angiomyolipoma. So we said adenomas were a possibility. Renal adenomatous tumors can be seen either as nephrogenic adenofibromas or as embryonal adenomas. Typically, again, those patients are going to be asymptomatic, and so oftentimes this is an incidental finding when we're imaging for something else, but hemorrhage can occur if the mass is large, or if it has hemorrhage, then it might be palpable, so then we might be looking at the kidneys because of the palpation. It can cause hematuria also, so that would be another indication for exam is hematuria, and we find an adenoma.